Welcome to What's Your Story? We have a fabulous guest today, Dr. John Brosious. And Dr. John Brosious is a plastic surgeon, board-certified plastic surgeon. But the thing that I'm most impressed about you is that when you took your test, your exam to be certified, you were the highest in the country. I mean, the whole United States.
Yeah.
Your grade. That's amazing.
Yeah. Well, thank you, Judy, and thanks for having me. And yeah, that is correct. And so every surgeon, when you graduate your residency training to get your board certification, you have to take a standardized test, an objective test. And the plastic surgery one is 8 hours on a computer. And of all the plastic surgeons that graduated my year, which would have been 2013, I did end up getting the highest score in the country. So that's something I'm very proud of. And that doesn't necessarily mean that it translates into being a good doctor, but at least it lays the foundation. And so I did study quite hard during my medical school and residency training.
I think it does give you a good foundation for being a great doctor. Now, it's interesting. You are at the UNLV Kerkorian School of Medicine, right?
Yep.
And are you teaching there?
Yeah. So I'm an assistant professor at the UNLV School of Medicine. It's almost a new medical school. It's one of the newest medical schools in the country. As a matter of fact, we just graduated our first class of students last year.
Oh, wow.
So we're very proud of that. So yeah, I'm an assistant professor of plastic surgery. I'm also the director of the residency training program. So I'm not sure how much you know about medical education, but after medical school, you do 4 years of medical school, then you have to do your apprenticeship, which is called your residency. And so I'm a proud graduate of UNLV School of Medicine plastic surgery residency, and several years ago, while I was practicing in Pennsylvania, the faculty at UNLV asked if I would come back and basically be the program director for the residency program. So I've been doing that for the last several years, and actually my newest endeavor is something that I actually just notified the school about a few weeks ago, is that I'm actually starting my own practice here in town. So myself and one of my partners from UNLV, Dr. Joshua Goldman, him and I were actually co-residents together at UNLV many years ago, and then I graduated first, and I was hired back on as faculty, and then when he graduated, he was hired back on as faculty. So we've worked together for several years.
Amazing.
We decided to kind of strike out on our own, so the two of us are going to go open up a practice. We're shooting to open our doors on April 1st. So we'll still be affiliated with the residency program with the School of Medicine. We're going to keep our faculty appointments with UNLV. We already met with the dean of the medical school and then the chairman of the plastics department. So we're still going to stay involved. I'm still going to teach the medical students. I'm still going to teach the trainees. And so it really isn't going to change. My role for the education is not going to change a whole lot, but my physical office will not be located on the UNLV med school anymore. It will be somewhere else. Yeah.
And you'll take private patients.
Yeah, absolutely. So and that's one of the things that Dr. Goldman and I really wanted to do, was be ubiquitous, be available to everybody. One of the reasons that the two of us went on into practice together is that we both have this desire to take care of the underserved. And so we're still going to take all the insurance companies that are out there, including Medicaid, and so we really want to be able to take care of not just the people that have private insurance, but also people who are indigent, people with no insurance, for example, and that kind of a thing. And so that's what him and I kind of share similar values in that regard. So I'm not just going to go out and do Botox and breast augmentation in the suburbs. I still plan on maintaining a very busy practice at the University Medical Center, to do trauma, cancer, burns, and of course reconstruction. Yeah, that's going to be the focus of our practice. Him and I both do cosmetic surgery head to toe as well. And when you're in private practice, you almost have to do some cosmetic surgery to offset the bills, especially since we want to take Medicaid. And there are very few plastic surgeons in the state that actually accept Medicaid as insurance because the reimbursements are so low. So most doctors don't take that. But Dr. Goldman and I want to take that, especially since I do a lot of transgender surgery. A lot of that community is on Medicaid. So to offset the fact that I sometimes lose money doing surgeries. I know it sounds crazy to think you're doing an operation and you're actually losing money, but sometimes the reimbursements are so low that him and I will do these big complicated surgeries, and at the end of the day, we get paid less from the insurance company than to even pay our office staff during the time we're operating. So we still want to serve the community. We want to offer those services, but in order to do that, we have to offset that with some cosmetic surgery. Yes. So we'll do a little bit more cosmetic surgery, and that's something that is certainly, we do help people by doing those surgeries, but our real passion is the reconstruction. That's why we decided we'd be a good team together.
That's wonderful. Tell me a little bit more about the surgeries you do for transgenders, because, we don't hear about it very much. It's not done very much in this country.
No, it's something that it's something that is kind of it's for me, it's my brand new niche. I never thought in a million years I would end up in Las Vegas doing gender affirmation surgery, but I do the highest volume chest surgeries for the transgender population here in the state of Nevada, and I'm the only surgeon in the state of Nevada that does the genital surgeries for the transgender patients. And so if you want to kind of take a step back and talk about just what is gender surgery or transgender surgery, so the first thing you have to talk about whenever you're talking about the transgender community, the LGBTQ community, you have to learn about what the lingo is, what's the semantics, and this changes almost on a daily basis. And so 20 years ago, we would call these sex change operations. Mm-hmm. And that evolved to something called, maybe a gender confirmation surgery. And then that kind of evolved to a gender affirmation surgery. And then now really we just call it gender surgery. The reason that we don't call this sex change, and the reason that we don't call this even gender confirmation, is that those two terms imply that these patients were born one gender and then changed to another gender.
Right.
And in reality, these people have been the same gender since birth. They're basically their mind and their body have not been congruent. So it's not like something happened at age whatever and all of a sudden they changed and became a woman or changed and became a man. All along in their own mind they felt that way.
Yeah.
And so a more appropriate label would be gender affirmation surgery, which is affirming what they already knew about themselves, or just gender surgery. That's just the easiest way to put it, is just gender surgery, because sometimes it's not just transgender patients. And so if you think about the spectrum of genders, the ones that we hear about the most obviously are male or female, and we hear a lot about the difference between trans and cis. So trans just means you're an opposite from the gender that you were assigned at birth. Whenever we're born, somebody puts on our birth certificate based on our genitalia, are you male or female? And we refer to that as assigned female at birth or assigned male at birth. A transgender person was assigned a different gender than how they identify. And so depending on where they are in their stage in life, they basically will come out and say, this is not, even though my body is male, for example, my mind is female, so I'm female. So that's a transgender person versus what's called a cis, C-I-S. A cisgender person would be like you and I. So, I was assigned male at birth, you were assigned female at birth, and I'm male and you're female respectively. So we're called cisgender. It goes back to the Latin or Greek or wherever that came from.
Oh, okay.
And so then you also have non-binary patients. Non-binary patients are those who don't necessarily identify as male or female. They're kind of somewhere in the middle. They have features. When they view themselves as maybe features a little bit of both, but not one or the other. Then you have gender fluid, which means based on their social situation. They may be male, during the day, maybe female in a certain social setting, that kind of a thing. And there are something like 50 genders out there. So there's a lot more than just transgender. It's just gender surgery. And so the overwhelming majority of my patients, I will say, are transgender, but we can't leave out some of the other people that fall into the gender non-conforming blanket, that gender. The gender expansive community is kind of the blanket statement for this population. So when you talk about gender surgery, then, well, what is gender surgery? So we kind of talked about genitals and chest. That's the more obvious. I'm going out into practice with. He does facial feminization surgery. So that's basically modifying the jawline, hairline, nose, cheek structures to appear more feminine, to be more congruent with your gender role. There is an ear, nose, and throat colleague of mine at UNLV who does tracheal modifications. It's basically the Adam's apple procedure. Is kind of the layman's term for that. And then there's also voice modification procedures that ear, nose, and throat doctors can offer to change the pitch of the voice. Then you work your way down to the chest, and that's where the bulk of my practice is chest surgery. And that would be basically doing chest masculinization for the transgender men. So when you talk about a transgender man, that means they were assigned female at birth and identify as male. So that's a transgender male. However, the easy way to remember that is however they identify, Judy, that's what you call them.
Okay.
So if this person comes into your office and says, I'm a male, regardless of what they were assigned at birth, if they say that they're a male, then they're a male. And so we'll call them a transgender male if they were assigned female at birth. So I do the chest surgeries for the transgender men. I do hundreds of these a year, and that's basically doing what I call a cosmetic mastectomy. So unlike a cancer patient where you are removing the breast tissue to take away a disease, with these patients, you're removing the breast tissue and you're trying to shape a male chest. So you kind of have to reconstruct the nipples. You have to make the chest nice and flat. You have to be very cognizant of the contour of the chest. And you have to be very cognizant of where you're going to put those scars so they can be hidden. Whereas if it's a cancer patient, certainly the appearance is something that the patients care about, but the primary goal is get the cancer out of their body.
Right.
If it looks good, that's a home run. But the primary goal is get rid of the cancer, whereas the primary goal for a chest masculinization is to make the chest masculine. So it's a little bit different of a procedure. And then switching gears to the transgender women, these women often have no breast tissue, so I do breast augmentation for them, which is pretty similar to if I was doing a breast augmentation for a cis female, using breast implants, that kind of a thing. If you work your way down even further, then there's the genital surgeries. And so that's something that there's only a handful of doctors in the country that offer the surgery. I myself, I'm the only one in the state of Nevada that offers any genital surgery for the transgender patients. And I actually just performed last week my 20th vaginoplasty. And so vaginoplasty is basically the creation of a fully functional vulva and vagina from a male anatomy.
That has to be an amazing surgery.
Yeah, these are big surgeries. These surgeries take anywhere from about 5 to 8 hours. The patients spend about 6 or 7 days in the hospital. It's quite a long recovery, as you can imagine. And but these are life-changing operations for these patients. And with the newer techniques, it's not so much as just amputating the hanging parts anymore. This is not simply just a castration. Because people always ask me, Dr. Brosious, what takes you 8 hours to amputate a penis? And I say, I'm not amputating a penis.
No.
I'm constructing a vagina and a vulva. And so these patients, I make a clitoris basically from the very tip of the penis, and I basically dissect out the nerves and blood vessels that go to that so they can actually have an orgasm. And I make a labia minora, which is the inner lips, and I can do that with either the foreskin or some of the skin from the penis itself. I make a labia majora, which is the fuller hair-bearing lips on the outside. I use the scrotal skin for that. And then I shorten the urethra. The only thing I really throw away are the testicles, as well as the erectile part of the penis that you don't need anymore. Everything else kind of gets repurposed, Judy. And then the scary part is creating a tunnel. It's creating the actual vaginal canal between the bladder and the rectum. And you don't want to damage the bladder or the rectum, because then those are very functional body parts, and then you can have stool or urine or whatever leaking into the new vagina.
Now I know you learned it in medical school.
Yeah.
But it just seems beyond my scope of what they teach you in medical school.
Yeah, it really is. I didn't, it's funny you mentioned that. I never interacted with a transgender patient in 4 years of medical school. I went to medical school in Indiana University. So, good Midwest medical school. It's a great medical school. But,
I thought you went to Notre Dame.
I went to Notre Dame for undergraduate.
Ah.
So I lived in Indiana for a long time. So Notre Dame is in the state of Indiana. I was there for 4 years for undergraduate. And then 4 years after that is medical school. And so I stayed in the state of Indiana, completed my medical school there. It was not part of our curriculum to care for transgender patients, whether the hormones or the surgeries. It was not even mentioned in one time in the 4 years I was a medical student, for multiple reasons. Number one, Indiana is a little bit more of a conservative state, so that's not something that they're pushing in the education. But for two, insurance wasn't covering hormones. It wasn't covering surgeries. And so there really wasn't a need for that. Patients weren't coming to doctors.
Right.
If they wanted surgery, well, they're kind of out of luck because the surgeries are really cost prohibitive. And so that's why there were only a handful of surgeons around the country doing it for cash, because most of these patients, they come from a marginalized, social situation. They can't afford to pay cash. And then the hormones, wasn't covered by insurance, so they weren't going to doctors for hormones and paying, to see a doctor and pay for pharmacy grade medications. They're going to the black market. Mm-hmm. So who knows what they were getting? But because the transgender population never really presented to the medical community until the last 10 years or so, it wasn't part of our education. So this wasn't part of my training. And even during my residency, 6 years as a plastic surgery trainee, I learned everything you can imagine. Hand surgery, breast surgery, reconstruction of the head and neck, gunshot wounds to the face, gunshot wounds to the hand, abdominal wall reconstruction, cosmetic surgery head to toe. One of the beauties of plastic surgery is that it's such a broad field. But nowhere in my training was gender surgery. Certainly I did breast reductions, I did breast reconstructions, I did breast augmentations. So I felt that I was pretty suited to learn some of these surgeries, but that was not part of the curriculum. And for me, this is part of the reason why I am staying on faculty at UNLV, even though I'm going into private practice, is that I firmly believe that this needs to be a part of our medical education.
Yes.
Insurance is starting to pay for some of these procedures around the country. Insurance is definitely paying for their hormones in most places in this country. And so the medical community needs to catch up and learn how to take care of these patients. And and even if you're not going to do the surgeries or prescribe the hormones, they still need to be able to interact with the patient population and being respectful and affirming to them. And so, part of my job is I know that most of the people that I train, they're not going to go out and do gender surgery, they're not going to prescribe hormones, but every single one of those medical students will meet a transgender patient one day, and they need to know how to interact with them,
Right.
how to talk to them, how to use the appropriate names and not use the wrong name or the wrong pronoun. And then some of the things that they need to know about what body parts does this patient have. Well, if this patient comes in and is a transgender male, that the students need to know, and the future doctors need to know, that this person, has a uterus and has a cervix and maybe needs screening that wouldn't necessarily you'd think for a man. So it really has to be part of our education to treat this community, and so that's the reason why I'm staying on as part of the university. But as far as learning these procedures, I had to go out of my way to find a way to learn them, because there's nobody in the state that does them. For example, if I wanted to learn some hand surgery, I would just call a local hand surgeon and say, hey, do you mind if I come down the street and watch you do a couple of these and help you out? And that would be able to learn that pretty readily. But for this procedure, I had to reach out to surgeons around the country who do it, and they're few and far between. So, of all the cold calls that I sent out there, only got a handful of responses, and most of them were like, we're too busy, or a lot of those surgeons were still kind of learning it and they weren't comfortable having people shadow them. But I was very fortunate that I did find a surgeon who was willing to let me go and shadow her and see these very complicated procedures firsthand, because I read every single journal article ever published from the 1990s to today in preparation of performing these surgeries. I watched videos and I went to conferences on genital surgery for the transgender patient. But I really needed to see them being done as well, just because, watching an 8-minute video or reading a paper on one specific part of the operation, I really needed to put the whole procedure together, because this is very unique. Even though I've done genital surgery in the past, even though I've done, treatment of burns to the genitals, trauma to the genitals, cancer, just birth defects of the genitals, doing a transgender surgery is completely different than all of that. And the anatomy is slightly different because they're on hormones, so things like the prostate are not in the same place or the same size and shape. And a lot of the patients have been kind of tucking their private parts for years, and that causes damage to the tissue. So I even spent a lot of time studying urology textbooks, because I needed to master this anatomy before I could master these surgeries. I eventually took my own vacation time, took my own money, and I traveled out of state and shadowed these surgeons and watched them do them, so that I could bring those techniques to kind of fill in all the gaps from everything that I had read and see how it's done. So I brought those techniques back here, and I started performing these here in Nevada in August of 2020. And so now I have them scheduled basically every week or every other week indefinitely. But that's kind of my journey into gender surgery. And people always, ask me, how did I get into gender surgery? Because I know that was probably going to be on your list of questions there. Everybody asks me that. Because it's a very unique specialty. And I never had some people think maybe I had a sibling, maybe I had a family member or a friend or an experience with a transgender person that I felt, I'm passionate about this. But that's not true. I never even really knew any transgender people growing up. I grew up in central Pennsylvania. There really wasn't a huge transgender population. Even if somebody was trans, they probably weren't comfortable even coming out.
No.
So I didn't interact with a whole lot of those patients, and then went through my education, my training. When I graduated from residency here in Las Vegas, I took a job back home in Pennsylvania, actually in Pittsburgh. I'm not necessarily from Pittsburgh, but my home state. And I went out into practice in the tail end of the recession. And so when you go out into practice in the tail end of a recession, you have to do anything to eat. It's not like your waiting room is filled with young women that want breast augmentation and you're just ready to go.
Yeah.
I had to work at wound centers. I had to take trauma call. I was on call at every hospital in Pittsburgh. I had to find ways to make money. And so I got this reputation that, Dr. Brosious won't say no to anything, because he's new and there's a lot of plastic surgeons in town and he needs to pay his student loans back. So people knew that if it was something that nobody else wanted to do, they'd call me up and I'd probably be willing to do it. So I started getting phone calls from transgender patients saying, are you willing to do gender surgery? And I told them, I've never done it, but I've done similar surgeries. They were really at that point just asking for the chest surgeries. That's really all these patients could afford then. And I said, I've never done it, but it can't be that much harder than doing breast augmentation, breast reconstruction, other breast surgeries that I'm comfortable doing.
Right.
I said, come on in, we'll talk, and I think I can help you out. So my first transgender patient, I'll never forget her. She came in, she was obviously transgender, just looking at her body and her build and her frame. And she came in and she wanted breast augmentation, and had a nice consultation with her. And at the end of the consultation, she started crying, Judy. And I thought for sure I used the wrong pronoun or I used the wrong name. I knew that I screwed up somehow. And I said, I apologize. What did I say to hurt you? And she said, no, you didn't hurt me. Really, you're the only doctor in all of Pennsylvania and Pittsburgh who treated me like a human being. That the other plastic surgeons,
wow.
as soon as they saw her,
Yeah.
they said, all right, well, we don't really take care of your patient population. And if she went to see primary care doctors, she said, like, oftentimes she would be shooed out of the office. So I was heartbroken, and so her tears were tears of joy, and that's when I had this passion, and I realized that there's a huge community out there that has been left behind by medicine, and as one doctor, as one surgeon, I think this is how I can make the biggest impact.
Yes,
and this light bulb went off in my head, and I said, you know what, I can make a huge impact on this population, as one doctor, and so that was my first patient. I did a few gender surgeries before moving here while I was still in Pittsburgh, but again, insurance was not paying for it there.
Yeah.
So when I moved here to Vegas, the word kind of got out that I am willing to perform gender surgery, and a few years ago, the Medicaid and most of the commercial insurances started covering these surgeries. The floodgates really opened up, and my practice just went from having one or two gender surgeons or gender consultations a month to now last week or the week before I did 7 surgeries just in 1 week for gender. And so my practice just kind of exploded, and at that time I was still doing the chest surgeries mostly, and I was working with other specialists around town, and that's one thing I realized is that a gender program is not like starting a hand surgery program or a breast surgery program. If I wanted to be a hand surgeon, I could go out tomorrow and I could build an office right next door, have maybe one occupational therapist, and I could be a hand surgeon. I don't need to coordinate a whole team of people. But for gender surgery, there's it really does, it takes the whole community to look out for them and to care for them. So you have your hormone doctors. There can be family practice doctors, endocrinologists, nurse practitioners, and so I had to reach out to all of them to find where these patients are and to find other doctors that we could share patients with. I had to find ear, nose, and throat doctors to do the neck surgeries. I had to find craniofacial surgeons to do the craniofacial surgeries. I had to find urologists, which is really a tricky thing, to do genital surgeries with me. I have to find OBGYNs to do hysterectomies for these patients. And so I also had to find advocates. I had to struggle with the insurance companies, so I have to find lawyers who can help me fight the insurance companies if I have to. So it was, if I had known how hard it was going to be, I may have threw in the towel earlier. But as I'm going along and I became more passionate about gender care, I realized, look, I'm not giving up. It has to be done. This is the only way to serve the community, is to basically form this network of community providers.
And as a person that didn't deal with that in my lifetime, I would not have imagined that you had to put together that big a team, that many experts, that many people. But when you say it, it makes sense.
It makes sense, yeah. And so it's not just like I'm doing a breast augmentation, then send the patient off. There's so many other people that are involved in the care of that patient to truly take care of everything, and not only just all the specialists required for gender care, but all of the other specialists like we talked about are just primary care doctors who are going to treat them for just good old-fashioned non-gender related conditions that need to know how to interact with them. So it was a huge project to get the gender surgery and just the gender care program off the ground. But like I said, something I've been very passionate about, and I think here in Nevada, we offer facial feminization surgery now, chest surgery, genital surgery. There's only a handful of states in the country that can say that we offer all of these procedures for the transgender population. So I'm very proud of that.
Oh, you should be. You should be. That's absolutely amazing.
Thank you.
As I'm hearing you talk, I've had a bit of reconstructive surgery myself. I had cancer in my breast, and so I had a lot of reconstructive surgery there. And also, years ago, I had a complete facelift, and I had it done in Africa. And it was amazing, the difference in the way I was treated and what went on in Africa than my friends who had it here in America. And it was also like my friends who've had facial surgeries done here, they look like they've been hit by a Mack truck. They're black and blue, and I had it done over there, and I had a big one. They cut me here, and they cut me here, and they pulled all this up, and they pulled all this back behind here. I've never told anybody this before. So
now you've told a lot of people.
Yeah,
so.
now I've told the whole world. So they did all this work. I had 65 staples across the top of my head, and I got one little bruise about the size of my fingernail right here. And 2 days after the surgery, I was at a big function in downtown Johannesburg, and nobody even knew it had happened.
Wow, you must have had a very skilled surgeon.
He was amazing.
Yeah.
But he told me when he did it, he said, you don't get a second one unless you do it before you're 65 years old. He said, you don't want to do it after that. Well, I didn't get it, so now I guess I can't go and do a little more work. But I'm fascinated with it because I know what I went through, and I see what other people go through. And then when you start talking about changing the gender, and I never even thought about the hysterectomy until you just said it a minute ago. I guess if a woman, if the body was female and she wants to be a male, or he wants to be a male fully, he would have to have a hysterectomy.
Absolutely, yeah.
Right?
Those pesky ovaries are going to keep producing estrogen.
Yeah.
So somebody who's would have to take extra testosterone basically to offset that. So part of it is the patients don't want to have a period. Essentially, they don't want to have menses because number one, that will cause dysphoria to themselves. But also, you don't want to take max doses of hormones, right? Because those have side effects as well. And so yeah, there's a lot of reasons that patients could want surgery that the general population doesn't even think about. And then the other thing, the corollary to that is that not every single person who is transgender or gender nonconforming wants surgery. So there are people out there, there are trans women and men out there, and non-binary people out there who they're comfortable with their body. They may have some dysphoria from time to time, but they don't really want the surgery. They don't need the surgery to feel whole. Yeah. They're happy with their body, and their mind and their body work just fine, and they don't need surgery. So, it's wrong. I think a lot of my students think, oh, they all want surgery, right? Well, it's wrong to think that. Some of them are perfectly happy, living in the bodies that they were given, and certainly some are not. And so I'm here to offer the surgery for those who want it, and for those who don't, that's not part of their journey. That's totally fine. And the world is becoming more, I think, an inclusive place. At least the United States, certain parts of the United States is becoming more inclusive, and people are becoming more comfortable just being themselves and being non-conforming. And so, yeah, surgery is for a lot of the patients, but it's not for everybody. Some of them are perfectly fine in their bodies. But, yeah, there's a whole spectrum of surgeries that are out there. Some patients want all of them, some want just some of them, and some want none of them.
And do you have to help them psychologically? Do you have to
absolutely.
sign them up with someone that can really help them with counseling?
Absolutely. There's a lot of mental health, being a transgender person, if you've ever spent a day with a transgender person, that life, the amount of stress that they have is enough to give anybody, depression and anxiety. And so there's a lot of comorbidities with depression, anxiety, a lot of PTSD. And so we have to tease out to make sure that these patients are ready. We're not trying to be gatekeepers. We're not trying to say, no, you don't get the surgery because, you have mental health issues. Yeah. A lot of the mental health issues stem from the fact that their bodies are not congruent with their minds. And so I do have a whole group of psychiatrists, psychologists, family therapists that basically will meet with the patient to make sure that they're good candidates for surgery, and to make sure that it's not that they can't have underlying mental health problems. We all have mental health issues. They just have to be controlled. And there's an international standard. So there's this organization called WPATH, the World Professional Association for Transgender Health. And they have put out their requirements, which I follow, which is for a chest surgery, there needs to be one letter from a mental health professional basically agreeing that they're a good candidate for the surgery. And for the genital surgery, they have to not only live in their desired gender for 1 year and be on the hormones, but also get 2 letters from 2 separate mental health professionals that have assessed them and that agree that they're making the right choice. So there is a vetting process for these patients. It's not for gatekeeping or anything like that. It's for patient safety, so that they don't make the wrong decision. So people, something that people always ask me is, well, what if patients regret this? This is something that, imagine you do the surgery and then you regret it. Statistically, the regret rate for example, vaginoplasty, this procedure I told you about, the regret rate for modern procedures is less than 1%. So this is only a fraction. I'm not going to deny 99 patients because one patient may regret this. When you look at things like cosmetic surgery, facelifts, those type of things, those have a 20 to 30% regret rate. So anyone that says, hey, you shouldn't be doing gender surgery because they may regret this, I say, well, maybe we shouldn't, as a community, as plastic surgeons, maybe we shouldn't do cosmetic surgery, because a third of people who get that are going to look in the mirror and say, I wish I didn't. And so regret rate is very, very low, and that's because of these international standards that have come out, so that every person who walks into the office doesn't automatically just get signed up for surgery, that they make sure that there is some clear mental health background checks on them to make sure that they are the right candidate and that they're not going through something in their life or this is a phase or that kind of a thing. So there certainly is a psychiatric component to it. There probably should be a psychiatric component to cosmetic surgery.
There probably should.
I mean, with the body dysmorphic disorder, those kind of things, they do say that the average patient, cosmetic patient, who comes into a plastic surgeon's office has anywhere from like a 5 to 10% chance of being body dysmorphic. And so, I mean, that means that every week I'm seeing somebody, who comes into my office who sees something in the mirror that I don't see and that I cannot fix, and they're fixated on this, and those patients will never be happy. And so, but it's hard as a plastic surgeon to send those patients to psychiatry because they get offended.
I was just going to ask you if some people have unrealistic expectations.
Oh, absolutely. It's I would say a lot of them do, and part of it is our own fault as plastic surgeons. When patients come to my office for cosmetic surgery, whether it's a facelift, breast augmentation, tummy tuck, mommy makeover, whatever it is, I say, go to my website and don't look at all of my competitors' websites and think that's what you're going to get, because we put our home runs on the website. If I do 100 breast augmentations a year, I'm going to put my best 3 on the website. And so are all my competitors. We're not going to put our average results. But if you think about the results of an operation, we're on a bell curve where you're going to have some home runs every year, and those go on the website. And you're going to have some patients that you're just like, I can't believe we did this to this person. And we want to hide that person from our websites. But most of the patients are going to fall somewhere in the middle and have an average result. And if you go into these procedures thinking, I'm going to look like this website, look like the models on the website, the patients are going to be disappointed. So one of the toughest things for me is making sure that the patients have very realistic expectations. Patients don't sue doctors in plastic surgery and cosmetic surgery especially for necessarily bad outcomes. They sue them for a lack of understanding what the limitations are. They sue them because maybe the doctor didn't explain, you're going to have lots of scars in order to do this breast lift. Or your breast, there is a chance of a capsular contracture, meaning you're going to have scar tissue around your implant's going to look a little bit weird. So, patients are dissatisfied when they come out of surgery and they see these results that they weren't expecting. And if the doctors would have just taken some more time to explain to them that, hey, look, these scars are there. There's no way around this, or these are risks of this operation, the patients may be more realistic and less upset. But again, patients oftentimes they think that they're going to be fine. Even if you tell them these are the risks, when they do end up having that complication, a lot of times they want to say, well, you never told me that. I'm like, I did tell you that, but you always think it's never going to be you. And so there should be maybe more of a psychiatric component to being a cosmetic surgeon. And so that's part of my training. And I tell my trainees, I say, look, part of it is you don't have a shrink that's going to check out all of your cosmetic patients. You have to do it in your 30-minute exam in history. You have to figure that out on your own. And if there's any red flags at all, don't operate on that person. And so that's something, there's a funny anecdote. My mentor, who sadly he passed away, Dr. William Zamboni, for example, he used to always tell me, never operate on a midline organ on a male. Hair, nose, or genitals. He said they'll never be happy.
Oh, really?
Yeah, and so the male cosmetic patient is a unique patient in that, the overwhelming majority of cosmetic patients are female. So when you see, and certainly there are men that have problems that they want fixed and that are concerned about their appearance, but there tends to be a little bit more body dysmorphic disorder amongst the males that come into the cosmetic surgery offices. So you have to be very careful about the male cosmetic patient because a lot of them maybe a little bit more narcissistic and a little bit higher expectations than some of the female patients. And so again, sometimes it's hard to tell in your 15-20 minute consultation, is this person going to be realistic or not? And that's really a skill that takes years of practice to develop that, because when you come out into practice, you think you can help everyone, fix everyone, and make them all happy, and then all it takes is a couple patients early in your career that are really unhappy with their results and make you really feel bad about yourself as a doctor. You think about it, to get into medical school, you have to be top of your class. You have to be, honor society. People all of your life have been giving you trophies and awards, and you're always used to being the best. And same thing with getting into plastic surgery residency. It's one of the hardest specialties to get into. So we're seeing the best of the best and the most brightest. They've never gotten a B+ in their life, only straight A's. And now all of a sudden, it's the patients oftentimes that give them that reality check.
Oh, yeah.
And that these doctors aren't, it's not until their mid-30s then they're out practicing and realizing all of a sudden the world doesn't give everybody a trophy, and your patients will be your harshest critics.
Oh, yeah.
And sometimes that's a hard pill to swallow as a new doctor.
Because even if you do the very, very best that you can do, it might not meet their expectation.
It might not meet their expectation. And it's a hard pill to swallow as a doctor. You're used to being told you're the best at what you do all of your life, you get the highest scores in the country on things like that, and now your patients are screaming at you because they tell you you're a terrible surgeon. And so after a few experiences like that, then you realize, okay, I'm not operating on everyone that comes in the door. I have to be selective. And unfortunately for me, I do mostly reconstruction. And so, those patients, they come to me with a problem and they need help. They're in a bind, right? They have cancer, they have trauma. Yeah. So they're a little bit more realistic about the expectations. The cosmetic patients you have to be a little bit more careful about.
Yeah, when I had cancer and they said you have to do the breast surgery, I wasn't really concerned about how it was going to look. But luckily the doctor was concerned about how it was going to look.
Yeah,
and so, what I thought was going to be a small scar turned out to be a big scar.
Yeah.
But it was in a place where it doesn't really matter.
Yeah.
So it worked out. It worked out well.
Yeah.
I want to ask you this because you don't look like a doctor.
I do get that a lot. Yeah, I do get that a lot.
I just wanted to ask you that because I heard a story when I was a young girl about if you had a choice between two doctors, would you select the one that looks like a doctor and has short hair and has his white coat and he speaks really well, or would you select the one that's got long hair that looks maybe like a biker that has a few tattoos?
A few.
Would you select one? And almost everybody said they would select the one that looked like the doctor, but that doesn't mean that person is the most qualified. And so when you walked in, I was like, oh, he's kind of like in that story, But I think when people talk with you, they would immediately understand. But tell me about these tattoos.
Yeah,
how come you got so many?
So your anecdote, your story is I can definitely relate to that because I went to medical school in the Midwest, right? Doctors don't have to, even nowadays. No, I really don't know any doctors that have tattoos. Certainly not visible ones. I always was very artistic. I like tattoos. I had a couple here during medical school and college that are hidden, and your arms, that kind of thing. And then when I moved to Las Vegas for my residency, I saw it's very different out here in the West, in the West Coast. All these big, beautiful tattoos everywhere. I said, "Oh my God, these are amazing!" And as a pasty white Irish American, I figured, it would be a crime to let this pasty white skin go to waste. It's the perfect canvas for bright, colorful tattoos. So I started tattooing my arms, very well hidden in a suit or that kind of a thing. And then I moved to Pittsburgh, and even when I got hired by my practice in Pittsburgh, one of the partners, when he first saw my sleeve tattoo, he said, "If I had known you had that, I probably wouldn't have hired you." And not after working with me, he realized, okay, that has nothing to do with his skill set.
It has nothing to do with your skill set.
It's nothing to do with the skill set.
But people have a tendency to judge people. My brother looked like the illustrated man. When, he started out with one tattoo in Korea, and by the time he got done, it was here to the ankles. It didn't change him as a person.
No, it's and it goes back to not judging a book by its cover. And so then, Judy, what ended up happening was the last several years, I started tattooing more visible body parts. That's when my friends and family are like, "You are crazy. You are a surgeon. You can't be tattooing your hands and your throat and all of this." And I said, "Look," and this is around the same time I started working with the gender population. And now I do about 75% of my work is gender surgery. And so I said, look, these people have been judged on their appearance their entire lives.
They're not going to be judging
They're not going to look at me and judge me for my appearance. And I have a unique patient population. Not only are the transgender population a pretty cool and open-minded population to begin with, throw Vegas on top of that, and they're even more open-minded. A lot of them have come here because they've been judged where they live,
right?
And they moved here to kind of create a second life. So they're not going to come into my office and look at me and say, I don't like the way you look. I'm like, I'm a doctor. And so it really made me, it's almost inspiring in a way that seeing these people every day be themselves, despite what society thinks about them, made me think, you know what? I mean, not that getting a tattoo is anything even closely related to walking in the shoes of a gender person, but it made me realize that, I'm going to be myself too. I don't care what, my family, my friends, and the rest of the medical community think about me, because my patients don't judge me. And so that's when I really started having this, tattooing more visible body parts. And I asked the patients before I started doing the hands and the throat, and I said, hey, what'd you guys think if you came in here and your doctor had a throat or a face or hand tattoos? And they would say, that would be so much more cool. Like you would, and I have patients tell me all the time, like the minute I see you, I realize, all right, you're a down-to-earth guy. You're not going to be judgmental. it's like almost like rather than talking to a doctor, it's like talking to a friend. A lot of my patients have purple hair and tattoos all very visible, and so they feel more comfortable with me. So I have a very special practice, being a gender surgeon in Las Vegas, that I can kind of get away looking like this, whereas you probably wouldn't ever see another. I probably am the only doctor with a throat tattoo on the planet, to be honest with you. And so that's kind of this. I'm a nonconformist, and I'm just kind of being myself, and I think that I see, I teach medical students and residents, and I think they see that, and I'm kind of leading the charge in that, you can still be a doctor and not necessarily look like a doctor. I always tell the trainees, hey, look, maybe wait until you kind of prove yourself a little bit nowadays.
Because they will be judged.
Yeah, you'll absolutely be judged. And so we're not quite at the point yet where, medical students are going to by and large have face tattoos and hand tattoos, but I think at some point we will get there where people aren't going to judge you on your appearance. They're going to judge you by your character. And I think that, I have a good character, and my patients recognize that, and there's no way they're going to, I will say most of my patients, when they come into my office, they've done some research on me, so they kind of know what to expect. It's the trauma patients that meet me on the day of, somebody, for example, my partners and I are the only ones in the state that do limb and finger reattachments in the state. So if you get your arm cut off or your finger cut off or your hand cut off, you have to come to the trauma center at UMC, and we reattach it if we can. And so those patients, they don't have time to do any research. They call me up and I walk in, and then they're like, all right. But it's either this or you drive to Los Angeles with your body part on ice, and good luck to you. So they don't really have much of a choice. They're just happy that someone's willing to help them there. And so those are the ones that kind of give me kind of that puzzled look when they see me, because they didn't have time to kind of look into me before they met me. But yeah, by and large, I haven't had any negative experiences being covered in tattoos, having the long hair. I think my family doesn't like it necessarily back east, but I'm just being myself, and it'd be one thing if I was selling drugs or not doing good for the community, but I kind of think that the fact that I am doing some good for the community offsets the fact that I look like I'm out there selling drugs. So I think it offsets a little bit for my family, my friends, and most importantly, my colleagues too, and my patients.
Yeah. Well, it's a real pleasure to have you here.
Thank you.
Would you look at that camera over there and how they can contact you if they need to or want to?
So like I said, I'm kind of in a transition myself right now, in that our new practice is going to be opening up April 1st to see new patients for cosmetic surgery, gender surgery, general reconstruction, breast reconstruction. We don't have a phone number or a website yet. We're meeting with some marketing people last night. So the only way to get in touch with me now, the easiest way would be to just call my office to schedule an appointment with me, 702-671-5110. We'll get you through to my current office at UNLV. I will only be there until April, so you'll have to get maybe search on the web or something for me after that. Mm-hmm. Or you can email me directly, John, John, .Brosious, that's B as in boy, R-O-S as in Sam, I-O-U-S as in Sam, at UNLV.edu. That email account should be available until April 1st. And so if people want to contact me that way, I can certainly put their name on a list or something like that, so that when I do open up my office, we can call them in for consultations.
Right. Well, wonderful. That's wonderful. I'll probably be one of your first people coming in there going, can you help me with this little problem I have? They told me at this liposuction place that I was going to look like this, but I don't. And I want it fixed.
Gotcha. Yeah, certainly glad to help. Anything. So we do anything head to toe, cosmetic reconstruction. Our niche really is gender surgery, as well as microsurgery. Both myself and Dr. Goldman, my new partner, we perform microsurgery. So that's microsurgical head and neck reconstruction, breast reconstruction, limb salvage. Basically, if it falls into the realm of plastic surgery, we probably do it. So you can reach out to us.
Great. Well, we'll look forward to it. Thank you for being here today.
Very welcome.
I learned so much. It was so wonderful having you here.
Likewise. Thank you very much for having me.
Thank you. And thank you for joining us. And if you have a story that you would like to share with someone, or you would like to write into a book, please stay tuned, because we have an offer for you in just a moment. Do you want to write a book, but you're not sure where to start? Well, what better time than now? You can learn how to plan, write, and launch your book in just 4 weeks. Writing and publishing a book can give you huge exposure, and when done right, will help you establish expertise and authority in your market. When it comes to creating and launching your book, it may be tempting to just dive into the world of writing and publishing, but this can leave you feeling scattered, uncertain of your message, and overwhelmed by your to-do list. This is why so many people give up and books go unpublished and stories go untold. Planning is the answer, and that's exactly what this e-course will help you do every step of the way. When you have a plan in place for how you'll write, publish, and market your book, the process is much more enjoyable and achievable. Go to my website now, JudyMoreo.com. That's JudyMoreo.com, and learn how.